Good afternoon. Hereby I open this academic ceremony in which Georgios Mikellides will defend the academic thesis, Is This For Real? The Role of Advanced Placebo Technology when Using Transcranial Magnetic Stimulation in Clinical Practice. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Highly esteemed prorector, highly esteemed opponents, dear supervisors, family and friends, thank you for being here today and giving me the chance to present the work that I have performed in the last 5 years. Is this for real? The role of advanced placebo technology when using transcranial magnetic stimulation in clinical practice. Around 280 million people in the world have depression. Around 30% of these does not respond to antidepressant medications. Around 22% of people around the world use tobacco. Only 7% of smokers manage to quit smoking. We're in need of new innovative treatments in neuropsychiatry. Transcranial magnetic stimulation is a non-invasive treatment option for a variety of neuropsychiatric disorders. A brain stimulation technique based on the production of short magnetic fields by using an insulated coil placed over the scalp. Magnetic pulses produce weak electrical current that can activate or deactivate neuronal pathways. We will be exploring today the use of TMS in psychiatric disorders such as depression and smoking addiction, as well as in neurological disorders, epilepsy, and Parkinson's disease. Also, highlighting the large placebo effect in TMS and the safety concerns that might arise when we use TMS either in clinical or research settings. We can stimulate different regions in the brain, like the dorsolateral prefrontal cortex, which has a role in decision-making, cognitive and emotional processing, in inhibition, and associate the area with people suffering with depression or addictions, plays a crucial role in the mesocortical limbic system and the serotonergic system. Another area in the brain that we can stimulate is the motor cortex, for example, in people with Parkinson's disease or neuropathic pain. What is placebo? Placebo is a psychological phenomenon where people experience health benefits from an inert substance or treatment without medical effects, but due to their beliefs. We can see placebo in pretty much any clinical and research setting, also in TMS therapy, in randomized controlled trials involve TMS, and we need to use a special placebo technology in order to measure the placebo effect. Placebo effect in TMS can be measured by using double-blind randomized controlled trials. That's one of the studies we will be discussing today in the next slides. And in our study, we have used this special placebo technology, which is the same for either giving active or placebo, based on flipping the coil and following instructions from the machine. Also, in this machine, we have attached electrodes that can stimulate the scalp, providing somatosensory, auditory, and visual experiences to participants. In our first study, accelerated intermittent theta burst stimulation for smoking cessation, a double-blind randomized controlled trial that we did in Cyprus, we have used the theta burst stimulation, which is a novel method used in TMS that can provide neuroplastic changes in shorter amount of time. Neuroplasticity is the ability of the brain to reorganize its structure, its functions, and its connections. In these 89 smokers, we divided them into 3 groups. One group was watching smoking-related videos while receiving intermittent theta burst stimulation. The other group was watching neutral videos while receiving real TMS stimulation. And the other group was actually watching smoking-related videos while receiving sham stimulation. They receive 4 treatment sessions per day for 5 days, in total 20 sessions of ITBS. We have used objective and subjective measurements, such as the pigosmobilizer here to measure the carbon monoxide particles in the breath, as well as questionnaires to assess, for example, for dependency and craving to nicotine. We can see here our graphs, the subjective self-reports, showing decrease in the amount of cigarettes smoked from the baseline to the day 4. We can see here that all 3 different groups decrease similarly, with no statistical significance between the 3 groups. And we can also see this correlation here with the objective measure, the carbon monoxide, that also decrease within those days of treatment. We have also used subjective measurements, such as the Fangstrom questionnaire that tests for dependency. And we have used baseline measurements, end of treatment, 1-week follow-up. The same for tobacco craving questionnaire. And we can see similar results within end of treatment and first week, that in all 3 groups, we can see similar changes, and there was no statistical significance between these 3 groups. In the second phase, we have followed up these participants for 1 month and 6 months in order to see if there would be any changes between the 3 groups. We have found that the questionnaires we have used here is the Fangstrom, for example, the same as previously, and the tobacco craving. These questionnaires were given through telephone conversations with the participants, and we can see that at least for 1 month, the dependency and craving, it was better than the baseline. However, post 6 months, we can see relapse in all 3 different groups, again with no statistical significance between the 3 groups. Conclusion: active accelerated intermittent theta burst stimulation, if it's to be compared with people smoking, with people watching smoking-related videos or neutral videos, or smoking videos while receiving placebo or sham stimulation, they were equal. It has shown a large placebo effect in our study. Also, we have highlighted the use of the advanced coil technology in this double-blind randomized controlled trial. The next study we're presenting here is a retrospective study that we wanted to assess 24 patients in real clinic retrospectively, that they either receive 12 sessions, they either receive 30 sessions of TMS, 12 participants, or 8 treatments of ketamine, also 12 participants. The participants that they receive the 30 sessions ITBS, they were over 6 weeks' time, while the people that received ketamine treatment was twice weekly for 1 month, 8 sessions. We have used clinical assessments to assess for depression and anxiety, and we could see quite similar changes in both groups in terms of decreasing the depression and decreasing also their anxiety symptoms, as measured with Hamilton Depression Rating Scale, Hamilton Anxiety, and also the Beck inventory, which is basically self-reporting for depression. So again here, what it tells us, this retrospective study, that the effect of ketamine and rTMS treatment was similar across all 3 measurements that we have used. No differences in terms of outcomes, in terms of patients receiving either ketamine or rTMS treatment, and they were equally effective treatments. In the next case report, we're reporting a patient, a 28-year-old patient with a drug-resistant epilepsy that received 30 sessions of rTMS bilateral inhibition of the orbitofrontal cortex because of the context of her epileptic network that was hypothesized that involved the amygdala, the postcentral gyrus, as well as the somatosensory cortex. And the results, after 30 sessions, done 2 sessions 3 times a week within 5 weeks, a total of 30 sessions, the focal seizures decreased from 1 to 3 per day to 1 to 2 per week. Also, the aura that preceded these focal seizures disappeared. The patient reported self-satisfaction of 70%. In the next study, a case report of a 70-year-old patient suffering from Parkinson's disease. This patient reported symptoms on the left side, especially to do with Parkinson's. We have used different questionnaires to assess for the Parkinson's disease, such as the PDQ-39. We have used a Beck depression inventory to assess for the depressive symptoms. And also, we have used a mini mental state examination prior and post the 30 treatment sessions. Here we can see a reduction of the PDQ-39, which highlights the improvement in terms of the quality of life of the patient. Also, his mini mental state examination prior to treatment was 24, indicating mild cognitive impairment. Post-treatment, that was 26. That's within the normal range. Also, in the Beck depression inventory, the score was 70 prior to the treatment, and post-treatment, that was with a normal range with no depression. So symptoms of Parkinson's disease decreased during treatment, and they were maintained up to 5 months post-treatment during the maintenance phase. In the next slide, a case report of a patient who had depression and anxiety originally, a 19-year-old female that received 50 sessions in total for depression and anxiety prior to this event, receiving ITBS and CTBS, 30 sessions for treatment, 20 sessions for maintenance. However, she did quite well on these treatments, and she was maintained free from medication for 18 months, but she started experiencing OCD symptoms, so we have decided to use the FDA-approved protocol for her OCD. However, on her 7th session, she experienced a tonic-clonic seizure, and this here highlights the importance of assessing for safety when we are giving TMS, either in clinical or research settings. So this presentation highlights the role of advanced placebo technology used in randomized controlled trials, the ketamine and rTMS as a treatment option for depression, also the use of rTMS in neurological disorders such as the epilepsy and the Parkinson's disease, and last but not least, to be aware of potential risk being associated when we give TMS to our participants or patients in clinical settings. Thank you.
Thank you for your presentation. The opposition will now start and will be opened by Professor Jansma, professor of Professor of the Cognition of Language at this university.
Thank you. Prorector, dear candidate, first of all, let me tell you that I enjoyed reading your book very much. I learned a lot, and I congratulate you already to this achievement, also to the supervisors. Great work. You basically report your work in international and peer-reviewed journals, which is impressive. And you basically show that you are skilled in a variety of methods, including single case studies, retrospective methods, but also fundamental research in the laboratory. And you obviously are clinical experts in a variety of patient groups as well, and I think it's very good to read about that. I also enjoyed the introduction a lot because there was a great review of all the methods in stimulation. But I'm most impressed that you did all that actually while you are working in the clinics. So that's really impressive, and you could be proud of that. But of course, I also have questions, and I know probably for clinicians, it's more to see whether a method works to help the patients or not. But for me, I'm always also curious. I would like to understand what goes on. And you basically compare this electric stimulation like ECT and the NIPS and the ketamine with placebo. I would now like to not focus on the placebo. I only would like to focus on the working mechanism of the stimulation methods. And you write in your introduction on ECT, for example, that several theories have been proposed. You also say, and the stimulation might, for example, change regional metabolism, it might change blood barrier permeability, or it might change electroencephalographic processing. NIPS, you also refer to eventually being effective because of ongoing or induced neuroplastic changes. But there you focus on LTP and long-term inhibition and the synapse. And then I was leaning back and thinking, okay, so obviously these two methods alter something in the brain, but according to your list, the alternations, according to theories, are very different. Or is there a common denominator which both techniques do change in the brain, basically, so that we see it's a common ground, and as a clinician, it doesn't matter whether I do ECT or I do RTMS. I just would like to hear your view about this. Do we know already exactly what goes on?
Highly esteemed opponent, thank you for your compliments and your questions. As we stand, there is a lot of hypotheses as how ECT works and RTMS. We know that we can use different studies using PET or functional MRIs to understand, for example, the flow of blood in different regions, understanding the receptors of dopamine and serotonin if the desensitization is lost, for example, due to addiction or other reasons. But there is no clear answer in regards as which method to use. In ECT, it has been shown that perhaps it's more effective as a short-term management of depression, for example, so it could work quicker to get someone out of depression. But there was a study showing that 6 months down the line, both scores of people that they have actually received ECT or TMS, they meet. And the hypothesis behind it is obviously stated as perhaps the brain chemistry changes, different neurotransmitters are involved, but it's not quite a clear cut, and we still don't know exactly the differences between the two. There is the long-standing understanding and issues with ECT that it might cause short-term memory issues, while some studies come and advocate for TMS that actually can help these short-term memory issues when we give TMS in people, for example, they have previously received ECT. It depends of what kind of practice, what kind of background each clinician has and what he feels more comfortable with and what patients he has in front of them. As we stand today, patients come to you and they read so much about it already, and they can understand that having ECT, you have to go through general anesthesia, muscle relaxants, there is an induction of a seizure, while RTMS can happen in much quicker way that you can come for 3 minutes a day and then you can go home. So there are different, in terms of the differences of what patients and how severe perhaps someone's depression is in terms of choosing which method to go with.
Clear, also very informative. Thanks a lot. There has been, if I may, so you nicely compared the RTMS with ketamine, and you showed that there was not a difference. There's, I think, published in June was a study called ELECT-D. It was a pre-registered clinical trial on the comparison between ECT and ketamine, and they also showed there's no difference. So now if I do the equal math, saying the one equals the one, and I would say, well, they are all the same, where is the common denominator? And you clearly now say, well, we actually don't know yet, but you're the professional. Which of the methods would you prefer, and based on what arguments that come obviously from your empirical work?
Ketamine works very quickly if it's to be compared with other treatment options. The patient can relax in the clinic for an hour or two while relaxes into a mental state that can dissociate sometimes. And for some people, for example, this experience can be scary. For some others, they enjoy this kind of experience. We know, for example, in ketamine that there is a huge release of dopamine and glutamate in the prefrontal cortex. That is one of perhaps of the roles that ketamine can work. But there are so many other ways that ketamine is still not understood in a way that works, being an NMDA receptor antagonist, and it can increase the glutamate in other regions of the brain. What I could see recently, especially if I have patients that they're quite severe and they have tried different methods of antidepressants, I might offer a combination of rTMS with ketamine. Mm-hmm. And there are some studies to show, in a study that was followed for 2 years actually, that combination of these two treatment options, it could help someone to get out of depression quite quickly, especially if it's to be compared with antidepressants. ECT entails a patient going to a hospital, going through under general anesthesia. So I will reserve this method for people that they're more severe in the end of, for example, not eating, not drinking, being in a kind of a catatonic state. So if I have a patient being in a catatonic state due to his depression, I will think of ECT, for example.
Yeah, thanks. A very short one. And all this actually is then applied in patients who are usually non-responders to other drugs. Why would you not, say, give that treatment to all?
For rTMS or ketamine?
Well, both. I mean, if you combine them, you would like...
I think for rTMS, there is a huge argument, and there has been an argument even at the American Psychiatric Association, that especially for naive patients suffering from depression, they should be discussing the option for having TMS, because TMS actually has less side effects if it's to compare with antidepressants, such as like dry mouth, sexual dysfunction, weight gaining, etc. So TMS, I think it's out there, and we could argue that it could be given as a first-line treatment to patients. Thereafter is obviously if it's covered by insurances or it's covered by the Ministry of Health, or they will be paying privately. So those are these kind of things that we need to think and consider with the patients. But we do have patients, they come and they say, I don't want medications. So we have to discuss this and to find a rationale and assess potential risk of any treatment that we offer to patients. Ketamine is out there as well. I mean, there is the esketamine as the FDA-approved spray, which is a part of the ketamine out there since 2019, but it's usually, the way it was approved, is that the patient has to try previously antidepressants. But we know that patients do their own research, and they start to think, what's the best and quicker way to get out of depression? So I think we need to talk today in terms of adherence rather than compliance. And we need to sit down with the patient, put down our pros and cons of undergoing any kind of treatment, and decide together as what to do next.
Clear story. Thanks a lot.
Thank you.
Thank you, Professor Jansma. The opposition will be continued over an online connection by Professor Constantinidu. She's a professor of language disorders and clinical neuropsychology at the University of Cyprus. Please.
Good afternoon from Cyprus, and congratulations again for conducting the thesis. And I understand that a lot of the research questions that are addressed are clinically motivated questions. And so on that, I would like to ask the candidate to elaborate a bit more on the impact of the RCT line of research in terms of the smoking cessation, and especially in respect to the long-term follow-up findings. I'd like to hear more about the impact of that work and where you think you need to go next.
Highly esteemed opponent, thank you for the compliments and for your questions. That was a study that took a few years to do, and I suppose we had a lot of ups and downs through the process of recruiting participants for smoking addiction. I think what our study showed that we had around 80% of people reducing the cigarettes. That was quite a significant number, even though it was equal to the placebo effects. We followed up these participants for 6 months, and we have seen that after 1 month, there was a relapse of going back to smoking. There were different factors that played a role, especially after the 6 months. It was a period in Cyprus with the restrictive measures due to COVID-19, where people experience, for example, more stress. We cannot substantiate this statistically, but that was one of the thoughts that we had in terms of the relapse. We didn't have maintenance sessions, for example, within these 6 months. Research suggests that perhaps it's good for the neuroplasticity to continue by having maintenance sessions. We also seen that in those 6 months of following up these participants, we only use questionnaires that they were subjective. So these measurements were taken through a telephone conversation. So sometimes perhaps we can lose some of the real information or some of the objective measures that we did use initially, such as the carbon monoxide. So in retrospect, we could think that in that time of 6 months following up these participants, we could have taken more measurements, and especially biological measurements. The difficulties are there in randomized controlled trials, and especially when you have participants that they volunteer, that they will not easily come to you and give, let's say, a sample of their breath to check for carbon monoxide. We had some dropouts in terms of like not responding to phone calls. For example, after 1 week, out of the 89, 67 responded to us. In the 1 month, out of the 89, 61 people responded to our telephone calls. And after 6 months, we had a higher number, with 77 participants actually responded to us. So I think these are the difficulties that we're facing in randomized controlled trials, and especially when we have healthy volunteers in terms of following up these people and try to measure where they are. Also, we didn't account for any attempts or any other formal treatments that they might have taken, like nicotine replacement or other medication during that period, to account either for a relapse or not in terms of their smoking.
Okay. So if you were to continue on this line of research, then how would you change things to incentivize people to participate? Because these concerns are true concerns. And so if you were to convince a funding agency to fund this research, how would you increase the confidence of the reviewers to pursue it?
That's a very good point. It's a difficult journey, I will say, but it's not impossible. When you try to improve and help patients, that 8 million people around the world are dying from smoking, I think there is a huge incentive for researchers to try their best to recruit as many people as possible that they are smokers. And what we have seen is we've seen a huge reduction of the craving and the smoking nicotine dependency by our treatments. So I think there is a huge incentive to participants that they can be helped to give up smoking that is actually a major risk for their own lives. So through advertising, social media, the way that we can advertise to promote in a way smoking cessation, and how much of marketing in that essence it can be done to get to every person in Cyprus, let's say, that there is a way to come out of being a smoker, and it could have a huge potential for their own physical and mental health.
Thank you. My other question has to do with conceptually integrating the different studies. So the first two studies relevant to smoking cessation, then we have the retrospective study, and then the single case studies. And so I wanted a little bit deeper thinking from your end in terms of how are the single case studies conceptually related to the overall theme, and how would you use the outcomes of those single case studies for further research?
Thank you. Single case studies are very important in a way to stimulate researchers to look at different ways of managing individuals in a way that you can improve the outcomes of the causes that they have. For example, we know that there is drug resistance in pretty much most of the neuropsychiatric conditions. So we need to find ways to individualize treatments. One suit does not fit all. We need to come out of that idea and trying to find ways how we can accommodate someone's difficulties using FDA-approved treatments. And sometimes we might need to use a TMS off-label based on previous research findings.
Okay. And do I have time for one question?
Yes, you have time for one more short question. Yes, please.
Okay. The last study on the seizure on the seizure occurrence with the OCD treatment. Since we cannot link directly the rTMS treatment to the seizure activity, do you think the study will create undue concerns about the safety of rTMS, since there have been several studies establishing safety parameters?
Good question. So we do know that seizure in TMS is a rare event, perhaps 1 in 60,000 sessions. Some risk factors are out there pointed out by researchers and clinicians. I think it's important to bear in mind that this is a potential risk to our population, either in research or clinical settings. It's a rare event. Medications, for example, antidepressants, antipsychotics, can also reduce the seizure threshold, but it's a medication that has FDA approval and people take it for their depression or their psychosis. So we just need to bear in mind that there is a potential risk, but we should not demonizing TMS for a rare event, and we should take into account the potentials that rTMS has and the side effects, which are very, very limited if we compare them with other forms of treatments in neuropsychiatry.
Thank you.
Thank you. The opposition will be continued again over online connection by Professor Goebel, Professor of Cognitive Neuroscience at this university.
Thank you very much, Pro-Rector. Dear candidate, I also want to first express my congratulations for this very interesting thesis, and also I want to congratulate your supervisors. I was especially impressed also by which you read between each line, your high motivation to help to bring the latest neuroscience technologies really to the benefit of patients, which is very important, of course, right? And I have a cold, and that's why I didn't come. I'm here in Maastricht, but I didn't come to the defense. And I took before I came a few hours ago aspirin tablets, right? And aspirin worked for a long time without that people knew how it works, right? And therefore I want to make a plaidoyer for trying things out and to the benefit of people who need it, even if we do not yet understand how things exactly work, right? But of course, as a cognitive neuroscientist, I try to dedicate my life to the question how things work, right? So therefore my questions will be a bit more towards the other side, but please apologize that they come from a easy point of view where you have endless of time, and I'm not in a real clinical environment. So I appreciate what you do. What my question to the first two chapters, but also to others, have to do with what you assume, or what certain established treatments assume what happens like in the brain, in the sense, which networks or regions do you want to stimulate, say for the smoking cessation study or studies, and why you think it should have an effect? So which target region is, and which, say, change in cortical excitability, why this should have an effect in reducing craving or reducing the wish to smoke? What is your rationale behind that study?
Hi, esteemed opponent. Thank you for your compliments and your questions. There are different regions in the brain that are stimulated through TMS for smoking cessation. We have seen studies that stimulated the dorsolateral prefrontal cortex, the left one, that there is a crucial role in the mesocortical limbic system, whereas we know, for example, in addictions and smoking, there are issues with the action of dopamine. In some of these receptors, perhaps there is some desensitization, there is some blunting of these receptors, and we can see that these areas has to do with the impulse control as well, that patients with addiction, they have issues with, let's say, controlling their craving. So they're in difficulty of controlling their craving, so they will go back in terms of getting their nicotine, getting their dopamine increase. So this is an area that has been studied and has been hypothesized that has a crucial role. We have seen also that BrainsWay has gained an FDA approval with the bilateral stimulation of the prefrontal cortices and also the insular, which has been seen, for example, in patients that had a stroke on their insular cortices, that they wanted to smoke less. So there are different areas in the brain that has suggested to clinicians and researchers that could be helpful in terms of substituting, embracing, improving neuroplasticity in this area, and perhaps through neuronal modulation, changing the status quo as addicted people into something more physiological and healthier.
Thank you very much. This was very clear and matches to some extent my little knowledge about that. But I learned, of course, a lot of new things also from your chapters. The question is a follow-up which I have, namely, you nicely described that there are prefrontal areas connected, say, to mesolimbic subcortical cortical structures, which are crucial here. And that's precisely what I wanted to hear, because my question is, you probably because of daily clinic have not the possibility probably to do an MRI or even a functional MRI, because my question is, would you expect you would achieve effects of TMS which go well beyond the placebo effect if you would have the possibility to localize precisely the entry point in the dorsolateral prefrontal cortex, which has in this person the connectivity to these mesocorticolimbic structures, so that you remove a variability with this more purely head anatomical based localization strategy. There is some evidence in the past that the more precise you localize the stimulated region, which as an entry point into specific networks you are targeting, has indeed a beneficial effect, so that the efficacy, the size of effects increase quite visibly, quite substantially. Would you expect then the same? So would you expect stronger effects, hopefully even surpassing the placebo effect, if you would use a better target localization using fMRI?
And there are some studies that they have used fMRI guided and MRI guided stimulation, and suggested that perhaps if we go more laterally, we will get better results in terms of smoking cessation. I think what we need to bear in mind that perhaps in the future we will individualize treatments, we will have a better understanding of each person, that, as I said earlier, one suit does not fit all, and we need to understand through fMRIs or PET scans and different ways of analyzing this data, which region, more specifically, we should be stimulating.
Yeah. Yes, then we agree also on this. I have a last question if I have time.
Yes, absolutely. Please continue.
Thank you, Professor. I have a question basically to all chapters. Somehow this is a question being valid maybe to all chapters, namely, when you look at your effects in the chapter 4, the effect size was equally strong, we heard this before, for ketamine and TMS treatment. That could be also maybe because you trigger some similar cognitive processes, some expectations, again related to placebo. And also in your single case studies, if you imagine that you have people who need help, as we discussed at the beginning, and they get a special new treatment, an exciting treatment, you might trigger strongly into the placebo effect because you as a patient, you want that something works and that you improve or reduce your symptoms, right? So this is fully understandable that placebo effects kick in, and rightly so, because they have an effect. I wondered when I looked in all these chapters whether it would be important to study and dissect which symptoms are more prone to potential psychological effects and which symptoms are not. What I mean by to disentangle placebo from, say, additional effects. For example, when you have this single case study of, what was it? You had Parkinson and, let's compare Parkinson and depression, not obsessive compulsive disorder for now. I could imagine that for depression, placebo effects might be strong, but let's go to the epilepsy case, because the frequencies of seizures, I cannot so easily imagine how your mental state, your expectations modify them, because these seizures might be built on some random fluctuations of neurons in the brain, and I'm not so sure how much we can influence those. I might be wrong, but the details is not so important. My point is, can we dissect what effects placebos have, and can we then make predictions on the effect size, how much these effects can be explained in a certain disorder? I know that this is done by cancer, for example. There people know very well placebo works for the real cancer process a bit, but for the side effects, huge, like depression or like other anxiety, huge. So what I want to say is, it would be maybe also important when we use TMS and other techniques, neuroscience techniques, to try to disentangle what are the symptoms we try to reduce and how much are they influenceable by psychological factors and how much they are not. And that might help us to better understand how different treatment options work. What do you think about that?
Thank you for your comments. I think placebo cannot be ruled out, even in the ketamine study or the case report studies. We know, for example, in Parkinson's disease, there is a high placebo effect from different and variety of treatments. As you pointed out, in epilepsy, it might be a bit more difficult because those are focal seizures that fully experienced by the patient. Different hypotheses can be suggested, an activation of endogenous cannabinoids receptors, for example, that can smooth down epileptic seizures through placebo effects. But it will be very difficult to measure and distinguish how much is placebo and how much is the active treatment, especially in case report studies. And when people come for expectations, high expectations for innovative treatment, and in epilepsy and Parkinson, I can say as well, we have used an accelerated form of TMS. Research also suggests that perhaps in accelerated versions of TMS, the placebo is even higher. So it will be very difficult to distinguish the real or active treatment of enhancing neuroplasticity and neuroplastic changes in the brain. Perhaps neuroplastic changes still happen. It takes time for them to happen, but we will find it difficult if we don't use, let's say, fMRIs or PET scans or any other ways to kind of like pre and post and see the differences in these areas by using the TMS.
Very good point. Thank you so much. I give the word back to the prorector.
Thank you.
Thank you.
The opposition will be continued again online by Dr. Chuck Muck. Dr. Chuck Muck is an associate professor of brain health at the University of Otago.
Thank you very much. This is a very comprehensive work, and it includes a wide spectrum of diseases utilizing the transcranial magnetic stimulation. So I would like to start with a technical question first of all, but before asking my question, I would like to be sure if it's valid or not to ask such a question. So I wonder about the noise or sound during these stimulations. Regarding the active and placebo, all of these stimulation modalities has a sound like stated in the thesis, 140 decibel for the noise of the stimulus.
Theme opponent, thank you for your compliments and your question. Yes, that's correct. It's the same coil that produces this amount of noise while either receiving real stimulation or sham stimulation.
Thank you very much for the confirmation. So in this context, I would like to ask your point of view about the stimulation, because then the stimulation come up as a kind of magnetic stimulation and also a noise stimulation to the brain, considering active and placebo, all of them are inducing a similar effect for smoking cessation. And as we know that, for example, acoustic startle response can be induced 95 decibel noise and beyond. So, and this reflex also considered to be traveling along amygdala and deep brain centers. So do you think that this might be a part of the effect beyond the magnetic stimulation itself?
Thank you for your comment. Definitely they can perceive the noise, but I wouldn't expect that the noise will have any real changes in terms of neuroplasticity, in terms of stimulating the neurons in the way that TMS does. But participants will experience the noise of the real TMS stimulation while they were actually receiving sham stimulation. And it could account, perhaps, that it could increase the placebo effect because of this experience.
Thank you very much. Another question is about the adjustment of the dosage. For example, considering Parkinson's disease, they start a particular dose of a medication at the early years of the disease, and during the progression of the disease, the medication should be adjusted and the dosage should be increased. So while you are providing TMS, this can be considered for all the chapters. Do you think that there might be an adjustment of the intensity of the stimulus? Will it be a better way of stimulating by using the TMS rather than providing, if this is the case, the same intensity at every session during the treatments?
I think what's important and what has been done in clinical and research settings at times is that you measure the motor threshold weekly. So you can see if the motor threshold has changed through the TMS sessions. So if we have seen any changes in the patient's motor threshold, accordingly, we will adjust the intensity.
Thank you very much. So this was the case in your studies, to my understanding.
Yes, that's correct.
Thank you very much. So I have a few questions about the region selection as well, and considering the age. For example, when looking at the age range, for example, at least at one study, it was in between 18 years old up to the 70 years old. So this is a quite wide range of age. And considering the brain, for example, 18 years old, dorsolateral prefrontal cortex is one of the brain regions that is pretty much maturing the latest in means of cortical thickness analysis showed us. So while dealing with the 18 years old as a patient and considering 70 years old brain, there might be some differences in the brain as an organ. And considering the stimulation, these differences might be considered. I would like to have your opinion. May you please elaborate a little bit about this aspect?
Yes, we hypothesize in research and in terms of the neuroplasticity that perhaps as we grow older, the neuroplasticity happens in a slower rate. So it might not be the same way that an older brain will react to the stimulation. And I suppose we should bear in mind this. Also, the motor threshold might be different in younger ages and in older ages. So in a way, we adjust perhaps the dose and the intensity based on the motor threshold, which in a way it could account for the differences in terms of how the brain responds to the stimulation.
Thank you. In the context of Parkinson's study, my understanding, the focus was M1 region. So considering this M1 region, did you consider a particular part of the M1 regarding the symptoms of the patient, like lower limb, upper limb? And do you also consider UPDRS scores while considering clinical improvement in this patient?
Yes, we have considered a contralateral stimulation of the patient's main difficulties, and we did not use, in a way, any possible MRI-guided stimulation. That could be a bit more difficult in terms of finding out the exact stimulation site. So it was more a general stimulation of the M1 contralateral to the patient's main difficulties. He also experienced pain on his leg. So we tried to account for that as well during the stimulation. And based on what the physiotherapy reported as well, the patient had a strengthening of the contralateral side of both upper and lower limb following our rTMS treatment stimulation sessions.
Thank you. And a question about the bilateral stimulation aspect. So my understanding, this stimulation is alternating in between the cortices rather than synchronized stimulation. From your experience and regarding this thesis related work, what is your opinion about providing alternating stimulus or synchronized bilateral stimulation to the cortices? Do you think there might be different effects and outcome?
Actually, it's quite important, your question, and we have now also a coil that can stimulate bilaterally, the double coil, which was not available to us prior in the past. But following the FDA approval for the specific coil, it's currently available to use for patients, which has a deeper penetration into the structures of the cortex as well. So potentially there could be differences. However, I will say that the participant or the patient experience a break between those accelerated versions. So I will say potentially there could be differences if you stimulating bilaterally or unilaterally, but the question and the answer is not there to say which one perhaps is better.
Thank you very much. These are my questions, if it's okay.
Absolutely. Thank you very much, Professor Muck. The opposition will be continued by Dr. Duggar, Assistant Professor of TMS Methodology at this university.
Thank you, Prorector. Dear candidate, I'm very much in tune with the praise that was already voiced by the other members of the opposition. So congratulations to you and also your team. And I would like to add that I think you're a pioneer. My understanding is that you're the first person to offer TMS service in Cyprus, so it must have been difficult. And secondly, I would like to highlight that bringing clinical work and research together is also a major challenge, and I think we need more of that to be successful as a community. So I'm very impressed.
Thank you.
I'm here to challenge you, obviously. My first question brings us right to the beginning of your book. Is this for real? Well, that is the big question. And when I look at the two first propositions of yours, the first one is that left DLPFC stimulation is effective. And the second one is that there's no difference between real and placebo TMS. In my mind, that is somewhat of a contradiction. And so I'm still wondering the same question that you had. Is this for real or not?
Esteemed opponent, thank you for your compliments and your questions. I think it is for real because we have seen double-blind randomized controlled trials. For example, in depression, it can be useful to patients. There is an FDA approval for a variety of neuropsychiatric disorders in terms of accounting and measuring the placebo and comparing this to an active treatment. So I will say that it is for real, and we should be thinking about exploring the ability of TMS in a variety of neuropsychiatric disorders, not just the ones that they have already the FDA approvals. And we should bear in mind how we should be individualizing treatments for our patients.
Thank you. If we make it a bit more specific then in the context of smoking cessation, right? There we don't have all that much evidence yet. Earlier studies found a difference between active and placebo TMS. But New York, you now come with this amazing TMS methodology, right? You have a state-of-the-art placebo call, you improved of prior work, and then there's nothing. So specifically for smoking cessation then, so what's your verdict so far then?
Thank you. As I said, Brainsway managed to gain FDA approval by using an H-type coil and stimulating specific regions such as the prefrontal cortices and also the insular cortices. I think a lot of research needs to be done to explore the potential of TMS in smoking and addiction. There are studies out there that they have used high frequencies like 20 hertz or 10 hertz, and they were double-blind and randomized controlled trials. Sometimes we had small numbers, but nevertheless, we can see that people can benefit from these treatments. We need to think and take everything into perspective and how we can develop perhaps bigger RCTs in terms of accounting for the placebo effect, in terms of finding out which treatment protocols are better or best treatment options for our patients.
Okay, so you're a believer.
I am a believer, that's why I'm here.
Fair enough, fair enough. I already mentioned that you have this quite sophisticated TMS coil that also allows for double-blind stimulation. That's obviously right up there with the best practice, so compliments on this. But then I couldn't help but be a bit surprised that you actually don't assess blinding success in chapter 2 and 3. So I wondered about this. You know, how do you feel about this in hindsight, and how would you change things if you could do this over?
Thank you for your comments. You're absolutely right. In retrospect, when we were thinking about that, I felt that was something that I should have done, and we could actually measure the efficacy of blindness in terms of participants in order to see how much of that was there. In hindsight, I will say if I was going to do this study again or improve this study, I will try to assess the blindness efficacy.
And how would you do that exactly? What kind of questions would you ask?
You can ask questions such as, do you think you were in the group of receiving an active treatment? Where do you think there was a placebo in your treatment? What makes you believe that? Was it based on the actual stimulation? Was it based on what you discussed between the other participants? Sometimes participants talk between them and they compare what experiences they have. So I will try to understand, I suppose, how and what kind of thoughts participants might have while receiving either placebo or an active treatment.
Thank you.
Thank you.
Sticking to the placebo theme, the TMS coil that you used also had this surface electrode, I assume, that you can attach to the head. And correct me if I'm wrong, but I think the purpose is to mimic the sensations of real TMS. So it's a control condition based on mimicking active stimulation with a placebo coil. In fundamental research, an approach that is more and more used and favored maybe even is to mask the sensations of TMS, both the feeling on the head but also the auditory effects. So I wonder a bit what your position is on those two alternative approaches of mimicking versus masking, and also maybe translate this to a clinical setting. Are there particular aspects there that might favor one or the other approach?
Thank you. That's a bit of a challenge there. Sometimes people might think that masking could be better than actual mimicking in terms of people experiencing the sham, and it feels more like real to the real thing if it's to be compared with the mimicking. I think there is a debate about which one is best, and I will expect researchers to try and discuss this in more details and think about it. I think that we could develop even better coils that could mask the real active treatment.
Okay, or we discuss it instead of other experts. Right? I think we have a few minutes left, so let's zoom out maybe. And in proposition 6, from a clinical perspective, you state, well, placebo effects are not so bad after all, right? They also get the job done. So maybe in one sentence, what's your take on offering placebo treatments to patients?
That's a huge ethical discussion. And I think we should be offering treatments that are not just placebo to our patients, are proven, active, and well documented in research and in clinical settings that work better than placebo.
Fabulous. Back to the prorector.
Thank you. Georgios Mikellides, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and their return in this room.
Thank you.
Georgios Mikellides, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Suck is authorized to confer upon you this academic distinctions in accordance with Dutch university custom. I invite your supervisor to now take the floor.
All right. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Georgios Mikellides, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. So George, I'm over here, yes. Maybe we should have explained a little bit more about the procedures that we have here. It's now custom that I say a few nice words. You can relax now. So as I said, George, or Dr. Mikellides, this is a special moment for me because it's probably the first time where I had to pronounce your full last name. Dr. Mikellides, I wasn't even really aware of it. Because until now, I just always called you George from Cyprus. But to be fair, it's also the other way around. You probably were not aware of all my titles and my last name and how I'm addressed here formally, because I was always just Alex from Maastricht and Teresa from Maastricht. This is how we communicated, this is how we got to know each other. But in the 5 years of working together, we actually were promoted. Teresa and I from Alex and Teresa from Maastricht, we were profs. So in all your email communications, and I looked it up, many of those emails, you referred to us as dear profs, which turned slowly into hey profs and hi profs. Have you seen my email, profs? I sent it 2 hours ago. Still haven't heard anything. What do you think, profs? So really lots of those emails. And if you don't get a hold of us, you started to email our secretaries, department, the PhD office, to find out what's going on. And this says a lot about you, your motivation, and how driven you are, and how eager, how much you enjoyed this scientific work, and how responsive you yourself are. So when we send something back to you with comments, you know, this data still needs to be analyzed in a different way, or this is something that's not really clear, just to tell you a little bit how my work looks like, you know, and I send it out, I have a feeling, okay, I have done this, you know, this is finished now, I can turn to the next email in my email list. But very quickly after, your turnover time is really minutes, literally, sometimes hours, but not weeks or months, what I'm normally used to when working in academia. So extremely quick. And you are therefore very special in many respects, because, and this is something that I would like to really point out here, that you are not the typical PhD student that we normally see that has full-time 40 hours a week, 50 hours a week to work on research only, because you are actually a clinician. You are treating patients. You are trying to help patients. It was nicely mentioned here also that it becomes very obvious that your motivation is really to help your patients. And you're working as a consultant psychiatrist in Cyprus, as a pioneer offering TMS service as one of the first in Cyprus, and this is your actual job. So you did research on the side, if you will. And how did you come to that cooperation with us? Well, this is also an interesting, and for me personally, very, very special day for my entire team, also Felix and Teresa and all the rest of the TMS team here in Maastricht, because you were one of the many clinicians worldwide that were interested in non-invasive brain stimulation and its potential to treat psychiatric disorders. And you wanted to learn more about it. So many years ago, probably 5 or 6 years ago, I don't know for sure, you decided to come to Maastricht to learn TMS in one of our TMS courses that we offer and that are so popular now among clinicians, offered by the Brain Stimulation Academy, or the Academy of Brain Stimulation, as it's also sometimes referred to. So you followed our course, as so many clinicians do, and this is where we first met, and then it was very clear that you were so fascinated by non-invasive brain stimulation and the potential to maybe start offering this to your patients that you wanted to contribute also to science. You wanted to find out how it actually works in a naturalistic setting, so not just in an academically driven strict inclusion, exclusion criteria designed RCT, but in a clinic with real patients with all comorbidities and so forth. You were wondering about placebo effects, for example, side effects. You also wondered whether, in addition to randomized clinical trials, what can we learn from case studies? So really looking at the individual patients. All things that now also today came nicely back in the scientific work that you did over the last 5 years, where you had the discipline to not only have the plan to do a PhD, because to be quite honest, we get this request quite a bit. Many people are, after following our course, very, very motivated to do something like this. But most of them drop out at one point because they realize, like you must have realized also, that it theoretically sounds really, really nice, but in practice can be very, very, very hard. It is extremely difficult to do a PhD, and especially difficult if you have to do it next to your work as a consultant psychiatrist, because it goes in up and downs. Data doesn't work out. Your placebo study is a good example. So you were so convinced and happy about offering, this nicotine treatment for your patients, and then we said, yeah, but you need to add this control and this control, and years of data collection, of analyzing data, and then in the end, the placebo is just as good as the real TMS. And I remember how disappointed you were, and I told you there is no need to disappoint me because this is science. We are not disappointed, or we are so used to disappointment that we don't recognize it anymore. This is extremely valuable. We publish it, and this is the basis of finding out what's going on, as so many questions were discussed today. So your journey was 5 years along. You learned how to design studies, you learned how to collect data, analyze and interpret it, and you learned how to publish and revise. So also this system, of course, is something that you are now familiar with, what it means to publish in international peer-reviewed journals. All of this next to your clinical work. So you're a pioneer, was also mentioned already, and you are the pioneer also in the sense of our aim, our mission to bring scientific research and clinical practice together, to bridge the gap, as we say, between science and clinical practice. And we motivate many colleagues to follow your footsteps, but actually you are here today on the 11th of September, it is the 11th of September, yes, 2023, you are the very first one who made it all the way to the finish line. So you're a pioneer and a role model of that kind of cooperation between science and clinical practice. And I know that many of you are dreaming to stand in your position a few years from now. One of them is actually standing right next to you, Theo, and I will practice your last name when it's your time. But Theo is trying to follow your footsteps as we speak. So it was a great pleasure teaching you and also learning from you, because we learned a lot about the clinical side of things as you as a psychiatrist. We hope that we stay in contact. I have many ideas for follow-up studies, even more controlled, to find out all the things that we were wondering about. Can we disentangle the placebo, non-placebo effects? Why? What placebo? So there's so much more to do. This is also that happens in science all the time. You answer a question, but you haven't answered it. You just created 2 more questions. And if you want to, we can continue, of course, this kind of collaboration. I, more than this, almost hope that your patients will continue to benefit from your innovative brain stimulation therapies for many years to come. And I congratulate you very much on that great achievement, and also your friends and family. You can all be proud. And yeah, congratulations, Georgios. Thank you. And before I forget, I really also want to thank the committee and the pro-rector for a very, very pleasant defense, and especially, of course, our external guests, Fofi and Yusuf. And Yusuf, as I mentioned already in the other room, thanks so much for being always on our committees, even though you're 12 hours ahead of us. So we'll try to wrap this up, and you can go to bed now then. Thank you very much. Thank you.
Thank you. Dear Dr. Mikellides, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. And I extend that congratulations to your family, your loved ones, and your parenymph, who also bravely stood here for all this time. I hereby close the academic session, and I have a few household messages for everyone here. There will be 2 more photos. So please make sure to join for that. Also, our online colleagues, you will be present at these photos on the screen, so please stick around for a bit longer. And thanks indeed for doing that, especially to our outside guests, Professor Muck and Professor Constantinidu.